Privileged to be here. I am delighted to spend a little bit of time with you. As I always tell my students and pre-healths all around the world, this is my way of paying it forward. The kindness that was shown on to me a long time ago, I am showing it back to you. I recognize the sacrifice that you guys are making by staying home and helping us in the front lines stay healthy. And so this is my way of thanking you. A couple of ground rules for today. The topic today is going to be the COVID-19 front lines, a perspective from an emergency medicine physician. I'm going to sprinkle in a little bit about my history and my path with some clinical scenarios, discussing some nuances about the care of patients with COVID-19. And then at the end, give you some practical advice on life, particularly on mental health and physical health. Those are my big ones. It is a pleasure to be here today and to thank you guys for this opportunity. I am going to make a very special announcement at the end. So you guys will be the first, and I'm talking the very first group that's going to get a hold of this announcement. So make sure you stick around toward the end. There is going to be an engagement activity going to sprinkle throughout the presentation. All you need is your phone or your tablet or your PC. Don't stress too much. I can't tell. There's no wrong answers, but I do want you guys engaged. Lana and Yasmin are going to be watching over the chat. I'll be stopping to answer any questions that you have, and I'll leave a little bit of time at the end for any kind of last minute issues that you got. So I'm going to start sharing my screen with you, and we will get started. Okay. All right. You guys see my screen okay, Yasmin or Lana?
Yes.
Okay, awesome. Well, guys, thanks again so much. My name is Gil Salazar. I'm an associate professor of emergency medicine at UT Southwestern here in Dallas, Texas. I'm a native of Guatemala, beautiful Guatemala in Central America. I am going to be sharing some lessons with you, dropping a little bit of knowledge your way. But I think if there is one lesson that I want you to take away today, has to do with this picture. I took this picture on a sunny Sunday fall afternoon. I don't get a lot of days off. I may get one day off a week if I'm lucky. Sometimes if I'm very, very fortunate, I might have a weekend off. But this was one of those rare times where I actually had a Sunday off. I was hanging out at home. My phone goes off, and it's one of my friends who happens to be about my age. He happens to be a neighbor, lives a couple of blocks away. And I've worked out with him for a long time, and through just kind of luck and I guess just a circumstance, we wound up being neighbors. He calls me and he tells me, "Hey man, I'm so sorry to bug you. I hope you're not working today. But I'm really concerned about something. I had surgery on my nose a couple of weeks ago, and I started having some shortness of breath and chest pain here earlier today. I'm a little bit worried. I don't know if I should seek medical help. I don't think I should call 911. And I just wanted to see what you think." It would have been very easy for me to just say, "Yeah, man, that sounds really good. It's really concerning. You should go see your doctor, call 911. But I know better than that. One of the biggest lessons I learned in medicine, and I hope that you take it away from me today, is that medicine is an endeavor of service and sacrifice. I was blessed with the opportunity to go to school and train so that I could be of service to folks using a very particular skill set to be of assistance to folks having a really bad day. And I would have never felt right if I didn't say to my friend, "You know what, man, let me put on my shoes, take my bag with me, and let me go take a peek at you, because I have the skill set to help you as much as I can." So instead of staying home and kind of watching some more TV or whatever I was doing, I grabbed my bag, grabbed my mask, and out the door I went. I snapped this picture not to actually, I didn't really want it to spread. I just wanted um, me in that picture with my bag so I could share it with my grandfather, who happens to be my inspiration and who gifted me that bag when I graduated from medical school. But then kind of the overall message of the picture began to make a lot more sense. So kind of lesson number one for the day is that medicine is an endeavor of service and sacrifice. So just remember that. A little bit about my career. I went to high school here in Dallas. I was blessed with an anonymous donor who happened to give me a scholarship out of her own pocket to pay for me to go to a private Catholic school here in Dallas. It's an elite Catholic school, and without this lady's kindness and her generosity, I would have never gotten a chance to go to this school, which really prepared me to go to college. I didn't know who this lady was. She chose to be anonymous for all 4 years of high school, and it wasn't until I graduated that I found out who she was, and I could never thank her enough for the kindness she showed me. So part of being here today is paying it forward. The kindness that I received along my path is the kindness that I want to bring to you, and hopefully you will pay it forward someday to other pre-healths. I went to Vanderbilt University in Nashville, Tennessee, a beautiful campus where I graduated with honors with a degree in neuroscience. I knew that I wanted to go into medicine at some point. I just didn't know when. To be quite honest with you, I was a little burnt out. Kind of during college, it was a beatdown. I decided to hang off on MCAT, and I went off to Florida after after graduation. And I don't like to call it a gap year. Gap year just kind of has this feel like you just wasted your time, and it's just like a gap in your life that you don't. It wasn't that. It was more of a year of growth. I had a lot of fun. I matured a lot. I was making a paycheck. I was working with a neurosurgeon in Florida who allowed me to be in the operating room, and I was earning a paycheck doing it. That really cemented my decision to go to medical school, where I was really fortunate to get interviews, and I matched with my top choice, which was UT Houston Medical School. I will save my decision on emergency medicine, kind of the actual true story, for another session, but I will tell you that it had nothing to do with medicine at all. It happened to be because of one individual, an emergency medicine physician, who struck a chord with me in terms of her passion, in terms of her service, in terms of her devotion to others, and just the vibe overall that I got from that field's personality. So it wasn't because of a particular patient or something kind of out of TV. It was kind of all very, very surreal to some degree. And I owe it to this physician for her kindness toward me, for mentoring me. And that's why I decided to go to LSU in Baton Rouge to pursue my residency in emergency medicine. It was during Hurricane Katrina days. That shows you how old I am, and kind of tells you why I have a lot of gray hair. But it was during that time that I decided to pursue a fellowship in emergency medical services. So I matched at UT Southwestern Medical Center here in Dallas. It was an awesome opportunity to come home. It was an opportunity to practice in a place that I had grown admiring. And the opportunity, I volunteered at Parkland Hospital as a young high school student, and the opportunity to come in as a faculty member for a world-class university is something I couldn't pass up. So it's my 11th year as faculty. They haven't kicked me out yet. Maybe at some point they will, but right now we're having quite a bit of fun. So I am not too different from you. And the lesson for my career path is that I can do it. I had goals and dreams, and I put my mind, my effort, made the sacrifices that I needed to do. And I was blessed with a lot of opportunities and kindness from a lot of people. And so go ahead and share that kindness going forward. Now that we're going to switch a little bit over into kind of my clinical duties. And a lot of you are very curious about what working during COVID-19 is like. So go ahead and get in, engage the poll right here. You can do it. Start with on your laptop or your iPad, and I just want to see what your overall understanding is on what's happening on the front lines of COVID-19. Remember, there's no wrong answer. I've seen 1 through 5. And for the most part, my goal for today is to bring any of you who might be a 3 or a 4 to a 5, and any of you who were at a 5, maybe kind of show you that maybe you didn't know as much as you think that you did. Remember, I won't be quizzing you. I won't be looking you up afterwards to ask you why you didn't do it. This is just for fun. Looks like the majority of you have a fair assessment. So let's go ahead and get a little bit of clinical medicine going. I trained to take care of anything that hits the door, and I mean anything. I am trained to handle trauma. I am trained to handle cardiac emergencies. I am trained to handle geriatrics.
Dr. Salazar, I think you got muted somehow.
There we go. Yeah, I don't know what happened. Okay. Where did I leave it, Lana or Yasmin?
You're just talking about what cardiac you're trained to do.
Yeah, thank you. So I was trained on handling older patients, pediatric patients, anything that you throw at me. So here we were just rocking and rolling, seeing patients, always busy. And then out of nowhere, we began to hear about this virus coming out of the Wuhan province in China. I can swear to you that it never in my wildest dreams that I think that all the training that you put into this and procedures and protocols for kind of worst case scenario would ever have to be used, because generally bad things don't happen to people. But this time I am here to tell you that that's where training and dedication and preparation really took effect. So we go from one day from just wearing kind of gloves and just kind of regular PPE to having to do exactly what I'm doing here, because on February 28th of 2020, I saw my very first patient with suspected COVID-19. It was a gentleman who had been traveling in Asia, had a stop in Japan, spent a couple of nights at an airport due to delays. He got on the plane, came home here to Dallas, and when he landed, he was feeling weird. Had a little bit of sore throat, some malaise. He didn't have any ill contacts that he could remember, but I will forever remember that whenever I saw the patient chief complaint pop up on my board, I often wondered when it would be the first time that I would see a patient with suspected COVID-19, and it was that day. My resident physician and I, Dr. Ty Stannard, we got dressed up with exactly what you're seeing here, which is our highest level of PPE for this type of encounter. And here I am wearing my surgical cap. I am wearing my N95 mask, which is an aerosol protection mask. I am wearing a surgical mask over that. And I am wearing a third mask, not so much for the mask, but for the shield. We know that COVID-19 is very easily transmissible through aerosols, and we need to protect ourselves very heavily. I got my disposable gown on, and I got a double layer of gloves. And what that does for me, it allows me to have an outer layer of gloves, which I can touch things and I can remove in case I need to go to the clean area, for example, and it gives me one added level of protection. So if, say, there's a breach on my outer gloves, I have a backup underneath. And ladies and gents, we have to be meticulous, because now everything that comes to the door, whether it's a cardiac emergency, a respiratory emergency, a sick child, a trauma, we're going to treat that patient like they have COVID-19. Part of doing what we're doing in the front lines is getting home safe to our families. And so we really take this seriously. You can see those signs right there to my right. To the left on your picture, droplet isolation, airborne isolation, and contact isolation. When you have those three in combination, that tells you that the patient is very high risk, more than likely with suspected or confirmed COVID-19. If I see those three signs on the door, I'm going to don my PPE very, very carefully. So kind of the lesson from this one is that life goes on. We continue to see emergencies. COVID-19 doesn't stop people from getting sick, from having strokes, myocardial infarctions. But one of the main lessons in medicine is you got to get home safe. You can't take any chances. And then shortly in the presentation, we're going to discuss the experience of some of the other frontline personnel who did happen to get sick. Okay, let's go to case number one. These are real cases. I know these are going to be posted in the public sector, and I got these cases with the permission of the patients and or their families, and they're not to be used for any other purposes other than educational purposes. I also use these cases to honor the victims of COVID-19, and I hope that you find them useful and you find them as a way to kind of further your motivation in education and medicine. This patient is a 71-year-old gentleman, history of diabetes, who's Spanish speaking, whose family brought him in after several hours worth of confusion and speech difficulties. The report that we got from the family is that he began saying some nonsensical things that are really outside of his normal. Even in his native Spanish, they were very concerned that some of the words he was saying were not making sense, and this is very unlike him. On physical exam, his initial set of vital signs show that he is hypertensive with a high blood pressure. His heart rate is normal. His temperature is normal. His respiratory rate is also normal. And his pulse oximetry, which we refer to as SpO2, is 97%, which is within normal range. You as a future clinician, you're a detective. You got to ask the right questions. And in emergency medicine, we don't have a lot of time to ask a ton of questions, but you learn to ask the right ones. And one of the things that became concerning to me was the fact that this patient had a family member living with him who had been diagnosed with COVID-19 recently. Some of you may ask, well, you know, his neurological exam was completely normal. So why are we even discussing this case? So the lesson kind of from this case that we're going to be looking at shortly is that things are not always what they seem. Okay, so I want to see what you guys think so far of the case. What is your diagnosis? And this one you can actually text it to 37607. Are we dealing with low blood sugar here? He is diabetic. Are we dealing with a potential stroke with confusion, speech pattern changes, etc.? Are we dealing with a psychiatric emergency such as a conversion disorder in which patients develop a neurological deficit that is not actual really present and is more of a psychiatric manifestation? Or are we dealing with sepsis, which is the severe manifestation of an infection? So drop your knowledge in there while I take a quick looks like a lot of you are going for low blood sugar, a little bit of stroke in there. Nobody's jumping at psychiatric emergency. And remember, there are no wrong answers in any of these. Okay, all right, let's tell you what we did for this patient. As part of a neurological workup for patients in the emergency department, we may need what's called a computed tomography, or CT, or colloquially known as CAT scan. That's going to be on your left-hand side. Basically, the way to look at this CAT scan, this is a cross-section of the brain. So the way you interpret this, the patient's head is away from you as the patient is lying down, and the patient's feet are toward you. So your left is going to be the patient's right, and your right is going to be the patient's left. What you're going to notice on the patient's right hemisphere, they're on your left-hand side, is that deficit all in black, which you don't see on the opposite side. That's one of the tenets in reading these CTs is you look for symmetry, and there's no symmetry on there. There's a large deficit which corresponds to the patient having had a recent infarct, lack of blood flow to that area of the brain. This looked relatively new, like it had happened in the last couple of days. But it can definitely explain some of the confusion, some of the words that were not making sense to the family, that were outside is normal. And that's one of the tenets in medicine. You listen to the family, you listen to your patient when you want to get a good history. In the workup of this patient, we also found that the patient had these abnormal ST segments and T waves. What you're going to see there in the EKG to your right, you're going to see the markings I say V1, V2, and V3. You're going to notice that upslope. That's they call the T wave. Okay, and I'm highlighting it. I hope you can see it, but it's the one that's pointing upwards, very, very peaky. Okay, those are called hyperacute T waves. In the setting of a patient who may have had a stroke, you also got to be worrying about blockages, lack of circulation to other places, including your heart. So, ladies and gentlemen, I had only read about this specific disorder in the literature. COVID-19, I didn't think that I would see it that early in the course of COVID-19, but here it was. COVID-19 causes a hypercoagulability syndrome, high clotting, over clotting. And it does so because of COVID-19 is a very inflammatory type of process. It affects inflammation in our air vessels. It also affects inflammation in our blood vessels. And one of the manifestations is very devastating, is that it can lead to, that inflammation leads to clotting. And that clotting can be everywhere. It can be on your brain. It can be in your heart. It can be on your legs, leading to deep venous thrombosis, blood clots. And it can be an absolutely devastating presentation in a complication of COVID-19. This patient, during his emergency department stay with me, which was approximately 2 hours, he deteriorated significantly. He began to be confused. He developed worsening ST segment elevation abnormalities in his EKG, so his heart attack was getting worse. I admitted him to the ICU after doing everything that I could, and this patient died within 24 hours of being under my care. There's a lot of talk about the survival rate is 99.4%, and this is not a big deal. I am here to tell you that unless you are ready as a community, as a person, as an individual, to go ahead and deliver the bad news to this patient's wife, his wife of 48 years, that the person she loves the most in the world has died, please don't talk to me about survival rates ever. Don't even think about it. COVID-19 is absolutely deadly. And yes, you may get lucky and beat it, but under no circumstances, guys, you, the future of medicine, don't ever let politics get in the way of the humanism of medicine. Having to deliver those news to this patient's family, which I chose to do because I speak Spanish and because I was so involved and so invested in this patient's care, was one of the most difficult situations I've ever been a part of. And I've done many death notifications and severity of illness notifications in my career, but this one hurt a lot, guys. So the lesson I want you to take away from that is that it is okay to be human in medicine, and don't let anybody tell you that there is anything more important than being a good human being and for using your skill set toward the betterment of humanity instead of downplaying or minimizing a pandemic. So if you have any family members or friends who want to talk about survival rates, I would be more than delighted to put them in touch with this patient's family, and maybe perhaps they can explain to them how their loved one didn't survive COVID-19. Okay, I'm gonna take a quick little break. So Lana and Yasmin, let's see what you guys got question-wise.
Yes. So first of all, thank you for your transparency and your honesty. We really appreciate that. I guess one of the questions that a lot of people had were if your hospital ever went through a PPE shortage, if so, how did you handle that? And if not, what measures were in place to prevent that from happening?
PPE shortages were one of the most stressful things for definitely my organization, and it's definitely top three concerns for every hospital system around the world. We went as far as, and we still do, reutilize our N95 masks. We limit our use of the mask to 3 uses. We were doing ultraviolet light disinfection and decontamination of our N95s, which would degrade their effectiveness, but we weighed the risk of that versus having to run out of N95 masks. They would leave a kind of a burnt smell, kind of unpleasant, kind of not, kind of weird, kind of tough to explain, but it just tells you that we work really hard at our PPE shortage. It's one of the reasons why we don't allow learners right now in the environment. Giving PPE to a well-meaning pre-health student right now puts a healthcare worker out of PPE. And so we've been having to be very aggressive with our PPE usage.
Thank you so much for sharing that. I hope that changes soon. Going back a little bit, everyone wants to know this, especially when it comes to emergency medicine, but how, if any, do you get any preparation to deal with, you know, bad news and delivering it to families, and, you know, how do you cope with that?
Yeah, we every medical student in the world, and many pre-health programs, including PAs and some nursing programs, have education and training on how to deliver bad news to patients. And I can tell you that you may learn it in school, but you're not going to master it until you've done it in person and you have a real human being with an actual disease process or a loved one who died for you to really master it. Everything from eye contact to where you stand to the words that you use to the amount of information you really do give the family or the patients. You need training for that. It doesn't get easier. It never gets easier, but you manage it better. Having a little bit of gray hair and having your own family and having been through it really helps. But it never stops being difficult telling somebody, you know, that this is one of the worst days of their lives and being part of that. And so the best advice that I have for you in terms of delivering bad news is that allow yourself to be emotional, and it's perfectly okay, and always put humanism at top of your priorities. In my program, Virtual Clinical Observation Program, we did an episode in which we did training on delivering bad news. So you guys can check it out. We'll talk about that toward the end. All right, we will get moving. You guys are bringing the good questions. Let's discuss a little bit about the day in the life of Gil Salazar. We talked about medicine being a life of sacrifice and service. The picture to your left is me with 4 second-year medical students at UT Southwestern. These are the cream of the crop. This is the kind of student that I want you guys to be. They've worked a lifetime to come and spend a Saturday with me to learn advanced cardiac life support, how to save somebody when they're having a cardiac or a respiratory emergency. I could have been doing anything with my Saturday, but it is part of my job responsibility to teach. And so I volunteered my time that Saturday morning to be with these very hungry medical students, and they make the sacrifice, I make the sacrifice, and because we both decided to make that sacrifice, this wound up being one of the most fun sessions I've ever had. These are elite students, guys. Like, you should always strive to be elite in everything that you do, but to go to medical school, PA school, nursing school, you got to be elite. Put in the time. They made the sacrifices, and so should you. And the payoff for you is to one day come and be in their shoes and come work with people like me and learn from people like me. Now, you know a little bit about my clinical medicine, you know a little bit of my teaching responsibilities, but I also get to have a little bit of a fun, really outside the box. I am a fellowship trained emergency medical services physician, which means that I get special training on field operations, anything that happens before a patient gets to the hospital, ambulance service, law enforcement, I get to learn about and train on. And I serve as the medical director for Hutchins Fire Rescue. Hutchins is a small city just south of Dallas. I get to play once a month with the fire department. Okay, so yeah, we're gonna run some medical calls. I'll jump in the ambulance with the guys, have a great time. But once a month, I also get to be a firefighter. And so we get to jump on the fire suppression apparatus, better known as the fire truck, and we jump in and we go take care of fire calls. We open folks who have been locked out of their homes, folks who have fallen, traffic accidents. I get to do something not a lot of physicians get to do. And that comes only because I've done additional training. And so the best advice I have for you, if you want to do some fun things in life outside the box, then go ahead and invest the time. Yes, there were 2 years of my life, but I would do it all in a heartbeat again, because I get the opportunity to do a lot of things not a lot of people get to do. To be a doctor and a firefighter and an EMT paramedic and functioning with my team, with the fire department, is absolutely one of the biggest joys of my life. All right, case number 2. Once we started once the patients started coming with COVID-19, they really started coming. And we had it down to almost a science, to the point that we could actually predict that the patient would have COVID-19 just based on the chief complaint alone that we get in our track board. And so this patient is no different. This is a 31-year-old woman, no past medical history, who presents with several days worth of shortness of breath, fever, after attending a 4th of July party, which had a component of an indoor portion of it. So it was a pool party, but they were indoors, unmasked. And so this young lady came to seek our help when she began to feel ill. On physical exam, she was hypotensive. Her blood pressure was lower than normal. She was very tachycardic, fast heart rate at 121. She had a fever. Her respiratory rate, which should be between 12 and 18, was very high at 26, and her oxygen saturation was very low at 72. In the right clinical setting for a 31-year-old woman who had no other past medical history or any other reason to be in the emergency department, this was screaming quite a bit of COVID-19. This was her X-ray. This is a typical X-ray for COVID-19. So just to orient you, and trust me, I don't mean any disrespect to those of you who had seen these before, but I'm trying to tailor the presentation for any of you who haven't. That's my job as an educator. The patient's, what you're seeing on your left-hand side is the patient's right, and whatever you're seeing on your right is the patient's left. The patient is facing you. You see both lung fields peripherally, and air is black. So preferentially, the lungs should be black. Everything in the middle that obstructs the X-rays basically going through, those are going to be solid organs. And you can see the patient's kind of aorta there in the middle. You see the heart silhouette there toward your right-hand side. But you see right there at the base of the lungs, they should be nice, black, and tight. You see all that cloudiness, all that haziness. Ladies and gentlemen, that is alveolar fluid right there. Remember, we talked about COVID-19 causes bad inflammation of your airways. Well, inflammation manifests itself in swelling, in fluid. And the reason these patients get in such trouble with COVID-19 and why they have difficulty breathing is because their airways, their alveoli, start flooding with fluid. There's a condition called acute respiratory distress syndrome, ARDS, that is one of the most common causes of mortality in patients with COVID-19. So sure enough, you get that history, you get this chest X-ray. You don't even need a swab. You don't even need to test that patient. You already know it's COVID-19. Of course, we test them, but the test itself takes approximately 45 minutes to an hour. So we start treating the patient like they have COVID-19, take every precaution, and see where they are. All right. What would you do if you were the emergency physician taking care of the patient? Do you go ahead and place an endotracheal tube, put the patient on the ventilator? Do you consider administering some high flow oxygen to the patient? Do you start some antibiotics and IV fluids on the patient? Do you let them go home after you treat them and discharge them home with some antibiotics? Remember, there's no wrong answer. Looks like the majority of you are choosing high flow oxygen. So we're going to be discussing a little bit about that here shortly. All right, looks like no other takers. Here's the deal. One of the scariest things about COVID-19, and it's been a source of frustration, is folks believe, well, you signed up for this, and hospitals are built for that. So what are you complaining about? When you have a pandemic and you have surges of patients, one of the biggest problems that you run into is, yes, you can have all the rooms, all the hospital beds in the world. There's no shortage of those. The problem that you run into is that you cannot create physicians, nurses, PAs, technicians, clerks, all our environmental services personnel overnight. The hospital, the health system would break down without people to take care of these patients. So when you are in COVID-19, in a surge of COVID-19, ICU beds and ICU staff become really a premium. You got to take care of them. Yes, in most circumstances, in any other day outside of a pandemic, that young lady would more than likely wind up being on a ventilator. But the problem is, if you put somebody on a ventilator, you're committing them to an ICU bed. That is one less ICU bed that you have for a sicker patient. And this pandemic has forced us to make some really, really tough decisions. One of the tough decisions that we have to make is use temporizing measures such as high flow oxygen, for example, which is basically a nasal cannula, and it delivers humidified, heated oxygen to the patient at a higher concentration to basically oxygenate them as aggressively as you possibly can and hope for the best so that you don't have to aggressively ventilate them on a ventilator. And that's been pretty successful. It doesn't always work, but it is one of the sacrifices that you make as a clinician. Having to tell somebody is, listen, I know this is not going to be optimal. We're going to do everything that we possibly can for you. We're going to start you off with the high flow oxygen. Okay. And a lot of these patients do well. Sometimes they don't. And if we need to, we wind up moving them to a ventilator. So once again, the lesson for this is the resourcefulness that you need to be an emergency medicine physician is very, very high. And the pandemic, what a lot of the public doesn't see is that it's put us in a really tough position to make some tough decisions on some very good people. And last but not least, guys, don't take any risks. This lady was 31, no past medical history, a life in front of her. And even though she wound up surviving COVID-19, she has now what's called COVID-associated pulmonary fibrosis. It's a severe scarring of the lungs, so much so that many patients wind up needing lung transplants, okay? And this is responsible for what's called long hauler syndrome. A lot of patients who recover from COVID-19 still have shortness of breath, fatigue, body aches, etc. And this pulmonary fibrosis could be one of the potential causes, okay? Let me discuss briefly what airway management looks like. This is one of my second-year emergency medicine residents, Chris Nelson. Chris is no different than you. He did go through high school and college and medical school. He worked his way up through the ranks, did well in medical school, and he eventually got into our program. To show you how difficult it is to do what Chris is doing, to come and learn to be an emergency physician, we receive no less than 2,000 applications every year for our residency program. We send out interviews to only approximately 150 out of those individuals. Out of those 150 individuals, we only matched 22. So for Chris Nelson to make it to the big leagues and come to learn an emergency physician, it's a testament to his dedication, his drive, the sacrifices that he makes. This is the kind of guy who would sacrifice his, while his friends were out on Friday, Saturday night, hanging out, the movies, maybe partying, he would be at the library hitting the books. So guys, I show you this to motivate you and to show you that, yes, you can do it. It takes some sacrifice, but you can do it. And the payoff is humongous. What Chris is doing here is we never stop training. Chris is doing here, he's training, practicing endotracheal intubation. You can see on his left-hand side, he's got a laryngoscope, which helps us basically push the tongue out of the way in the patient's mouth. And on his right, he's got an endotracheal tube, the tube with the green cap that you see on there. And you notice that he is looking to his right instead of looking at the patient's mouth, okay? So that's laryngoscope. It has a fiber optic cable that you can see there. It allows Chris to see all of the anatomy, allows him to see exactly where he's going, allows him to see the vocal cords, and allows him to introduce and watch the tube going in through the screen on his right. Okay. One of the reasons we train on that, especially during COVID-19, and one of the reasons for which you see that that box, that clear box, is that many of our colleagues, especially early in the pandemic, learned some very hard lessons about how COVID-19 got transmitted. It's an aerosolized particle. So a lot of our physicians who were intubating these patients using techniques and without significant PPE got sick. Many of them died. And this presentation is partly honoring them. Many of them became so sick that they wound up needing transplants, for example. And so their lives were absolutely devastated and decimated by COVID-19. And one of the lessons that we learned is that we were going to be sharing every little bit of knowledge that we could. In one of the ways we decided to reduce our exposure to COVID-19 is start using these intubation boxes designed by a Taiwanese doctor who very quickly realized that these particles could very easily be mitigated by using just a screen. So there is that acrylic box with a hole for your hands, and your level of exposure, we've shown that it's vastly diminished, and that keeps us safe. So if you want to one day come in and learn how to perform a life-saving procedure using the latest technology while preventing you from getting sick, put in the work now, and you can be in Chris Nelson's shoes very, very soon. So Yasmin and Lana, I'm going to take a swig, and I'll take 2 or 3 questions.
So you mentioned the long haulers, and so some people are wondering like what percentage of people that is. Will everyone have some kind of side effect? And then if you could touch just exactly on what pulmonary fibrosis is one more time.
Of course. Pulmonary fibrosis is a condition in which there is scarring of the lungs. It can happen in conditions that people are born with, like cystic fibrosis, for example. But we have learned that more than likely, because of the massive inflammation that COVID-19 causes, patients develop this chronic pulmonary fibrosis. It is impossible for us right now. It's too early to know just what percentage of people wind up with this long hauler syndrome. What I can tell you, one of the most interesting things that we have learned is that some professional athletes who develop COVID-19 are no longer performing like they used to, including in the National Basketball Association, for example, and including in the National Hockey League. I am one of the team physicians for the Dallas Stars, and I am not going to speak to any specific players or cases, but I can tell you that some players' performance definitely decreases because of COVID-19. It may very well be a component of pulmonary fibrosis.
Great, thank you so much for giving us that information. There was a question earlier that I thought was good. when you were talking a little bit earlier about, you know, what was the word? Just like being elite. How would you recommend striving to be elite and also not occurring burnout?
Yeah, I think I'm glad somebody asked that because I was hoping that you would. Okay. One of the things that I teach particularly my paramedic students, is the concept of let's be elite at everything that you do in life. Let's be elite at being good human beings, at being folks of service, being elite as sons, as daughters, as brothers, sisters, as workers, as co-workers. And part of being elite in life is also being an elite student, making the sacrifices where you need to, recognizing when you need to step away for a little bit, and constantly striving toward achieving a fine balance between your education and your life. So being elite is not just like, oh my God, I'm going to study 24/7. That's not what elite is all about. It's being a well-rounded elite individual. And being elite, as we're going to learn here pretty soon, involves having a good life balance, guys. And I can tell you that is a struggle that even people like me face. So I'm going to give you some clues at the very, very end. So remember, it's not just being elite as a student 24/7, it's being elite in everything, at every endeavor that you do. And if you put that level of attention and detail to everything that you do in normal life, then more than likely you're going to be an elite clinician as well. Let's take one more if you have one.
Yes, so there was a question that was a really awesome question. A lot of people are wondering the same thing. You mentioned the competitiveness of entering the residency. And so considering like mental health strain, and then also just how you're mentioning the shortage of like doctors and nurses, do you think that programs will start opening up more spots? Or if not, why do you think that is?
There is definitely a shortage of clinicians, particularly in the United States and to some degree the world too. I'm not well versed in global health as much as I would like to be, so I'm going to speak from the U.S. perspective. Only there is a shortage, and that shortage is being addressed with international medical graduates, for example, to some degree, and steps are currently being taken to open up more medical schools, especially in places like Texas, for example, where we've kind of almost doubled the number of medical schools trying to address this shortage. Now, let me be very clear on something, guys. Under no circumstances should we ever be satisfied with the quality of applicants coming in. And it's not because I think that people are bad people or they're not going to be good doctors, but not a lot of people are willing to make the sacrifices and have the commitment to service that it really takes to be an outstanding clinician. Yes, you have to be great at the diagnostics, the therapeutics, procedurally, like Chris is showing you here. But it is actually pretty rare to find a humanistic individual that you can trust your life on. And they're not just good at the medicine of it, but they're phenomenal human beings. So I am never, ever going to be satisfied, never going to be complacent in the quality of applicants that we take. The clinicians of the future are going to be taking care of my generation, and the people taking care of me and my family have to be the cream of the crop, guys, that lead in every aspect of their lives, most importantly at the humanistic level. So if you're humanistic, if you're willing to put in the time in being a lead at everything that you do academically and in life, you want to come and take care of me and my family someday. So yeah, let's work really hard toward making sure the quality of clinicians of the future is even better than this generation, guys. So I hope that answers the question correctly.
Yes, thank you so much.
You're
I think you're muted again.
All right, here we go. For us in emergency medicine in the front lines to stay healthy, some of the mitigation strategies that we utilize are frequent testing. And so this is me. I thought this picture was funny because we would go and get tested every couple of weeks as part of this effort. And so in order to not expose the nurses at the occupational health clinic, you would go for your appointment. They would put the swab there for you, lock you in a room, and that way you could take off your mask. And sometimes when you're being tested, you sneeze and you cough. So in order to not expose individuals, I had to learn very, very well how to shove that swab up my nose without hurting myself. And one day I decided to snap a picture of it and kind of share it with the rest of the world. Now, we would be tested for active disease and also antibodies in our blood. So in order, I would normally kind of pull you on this, but I am very happy to say that in all of the time that we were being studied and surveillance was taking place aggressively, I had zero positive tests and zero antibodies indicating that I had disease in the past. Okay. And that is not a testament because I'm a good guy or whatever. It is a testament to the kinds of sacrifices that we made by staying home, by wearing our PPE. And what a surprise when you're going to the grocery store, a simple public health measure like wearing a surgical mask. Wow, what a sacrifice could actually keep you healthy. What a concept. Unfortunately, in this country, we politicized simple, basic public health measures. And as a result, over 500,000 Americans have lost their lives. Let's not do that again. Let's not do it again. I did not develop antibodies until I had my second vaccination, which was one of the proudest days, one of the happiest days of my life. I was giddy. I was so happy. And I happened to get my vaccine on the first wave of vaccinations on the second day because of the kind of job that I do. Guys, 3 days after my second dose of the Pfizer vaccine, and I'm not advocating for one over the other. I just happened to get Pfizer. That's what was available. I developed some beautiful antibodies. If you want to see what the IgG antibodies look like on my test, follow me on Instagram and take a peek at that picture I posted. So the lesson for this slide is, guys, this is not the time to relax. I'm really very unhappy with my state government's decision to lift mask mandates. What that's going to result in is another surge of patients. It's been predictable since, putting people like me and my family at risk and continuing this pandemic. And I'm not okay with it. So you future clinicians on the world owe it to yourselves to always use science. Put science first when you're making decisions about medicine. Let's use the medicine. Let's use people who do medicine for a living to help you drive decisions. Okay. One of the things that was very impressive about COVID-19 and to a large degree very unfortunate was the rise in cases with patients with psychiatric presentations to the emergency department. Case number 3 revolves a 45-year-old gentleman with a history of hypertension, really as his only past medical history, with 2 weeks of ongoing anxiety, kind of panic attacks, sleeping poorly, going to bed, having trouble falling asleep and staying asleep. And the reason he came and saw us that day was because he started having some suicidal thoughts. When you speak to him a little bit more about his life, you find out that he's an insurance agent. He's got a family, and he was recently furloughed and lost his job due to the pandemic. And he's afraid maybe some retaliation because of his anxiety attacks that he had. On physical exam, he had a flat affect. He broke down in front of me. He makes poor eye contact with me, which is always a difficult thing to see. You begin to wonder what you're going to do for this gentleman. So I want to see what you guys are thinking about doing for him. Do you get a psychiatric evaluation? Do you get our psychiatrist on board? Do you think about initiating some medications on the patients? And yes, we emergency clinicians can prescribe psychoactive medications. Do you interview the patient further and see kind of what other factors are at play? Do you let the patient go with some resources for mental health? Now, remember, there's no wrong answer. in any of this. I just want to see what you think. Looks like a majority of you want to get a psychiatric evaluation. Some of you want to talk to the patient a little bit more. In the interest of time, let me share with you what I did for this patient. Everything goes back to service, in sacrifice, in humanism. I'm going to live by that. I'm going to die by that. I could have just said, okay, all right, let's get you some medications. Let's get the psychiatrist to come and see you. But I didn't make that decision. That's not me. That's not why I came to do medicine. I was going to be of service no matter what happened. And so what I decided to do is pull up a chair and sit down with him for 5 minutes. 5 minutes, I swear to you, 5 minutes. And discuss what are the things about his life that made his situation worse. I learned that he's a dad, that he's got a mortgage, he's got mouths to feed. I learned about his job. And even though I could never really quite understand what it's like to work as an insurance agent or be furloughed or not being able to feed my family, I was able to empathize. Empathy is different than sympathy. Empathy is that human connection you develop with individuals. And I try to my very best to develop that human connection with every patient I see. So yes, eventually we got him a psychiatric evaluation as an outpatient. Yes, eventually some mild medications were ordered for him. And yes, eventually the patient was discharged. But the thing that made the biggest difference in this patient's life on that day were not the things that I could just click on a button and order. That doesn't matter. And that's why I was telling you guys that I will never be complacent with the quality of applicants. I want people who are going to sit down with the patient for 5 minutes and learn about them. That's what medicine is all about. So this patient wound up doing remarkably well. He did wind up getting another job. He was able to save his house, and his psychiatric symptoms got a lot better. And I credit my mentors and many people who urged me and pushed me to be humanistic in medicine as one of the driving factors towards this patient's success. Okay. I'm going to finish up with one or two thoughts about balancing life. We talked about what are the things that are going to keep you in medicine for a long time. Guys, I work a lot. This is my day off. And my day off, I means I started my day with meetings at 7:30, and I am going to end it today past 6 o'clock because I wanted to do something. It is work related, but it is also giving back. So how do you take care of yourselves? How do you avoid burnout? How can you feed your family for a prolonged period of time? How can you be of service to your patients when you're at your best? I balance my work life with a few basic things, not many. Some things are very important to me. Number one, my family. When the pandemic hit, many people, many colleagues, many friends went ahead and self-isolated. I had the same conversation with my family, and my family and I made the decision that I was going to come home after every shift. It was taking a chance, but guys, without your family, you're nothing. Everything could be gone in life, but if your family's gone, then everything else is gone. Always hang on to your family. Your family comes first. My family comes first. They sacrifice their lives with me now. They take risks by being here, and for that sacrifice, I will be forever be grateful. And it's made me a better husband and a better dad. Number two, I'm big into hobbies. I'm not very good at many things, especially not cooking, but I'm very proud of some of the things that I do make that people like. Okay. And this was my Thanksgiving turkey. And cooking is one of my hobbies. It gets me distracted. I like the process. I like the ingenuity that goes into it. But what I really like the most is when people get to try what I made and they like it. That is very gratifying to me. Okay, so you don't have to have a lot of hobbies. Don't pick up 36,000 hobbies. Try to pick 2 or 3 that you really like. What really keeps me going, though, in terms of kind of balance, is my mental and physical health. Okay. This is my baby. This is what I strive for every single day. I am an athlete, a physician athlete. I work out, I do cross training with my teammates 4 days a week. And if you were asking if I do that unmasked, yes, because it's always outdoors. And to this day, we have had zero infections amongst my teammates. And we work out 4 days a week. Yes, we physically distance. Yes, we don't go indoors to bars, even though we're vaccinated. We always do it outdoors, whether it's rain, shine, it could be freezing out there. We're always going to be outside. And that physical challenge, that adrenaline, that sweat gets me going, guys. It gets me distracted. It helps me kind of offload and de-stress. And it really adds a good amount of value to my life. So much so that little Gil Salazar, who would have never thought this was possible, became a sponsored athlete by Circle Water through just some kind of miracle. Don't ask me how. They agreed to sponsor me. And so now I'm a sponsored athlete. So dreams can come true, guys. And I hope that you guys pursue this. Find that balance in your life, because work is hard. I don't work 40 hours a week. I don't work 50. Sometimes I work 60, 70, 80 hours a week. You got to find that balance. But that is different for everybody. Okay. All right. This is my QR code right there, which will take you to our virtual clinical observation program website. I run this program. I serve as the medical director. We have our monthly sessions in which we do recorded patient contacts. We have clinical cases. We do an extensive Q&A with my faculty colleagues who are physician educators. And we record the sessions. You guys can print out certificates and track attendance through our learning management system, which we partner with CareerCert. So if you're interested in registering for the program, we do charge a little bit because we partner with that LMS. And helps us keep the lights on, and we can provide scholarships to individuals. Go ahead and go to my Instagram if you'd like, check out the links, or the website has a registration link. So that is my plug, and my voice is almost dying. So I think it is time to get some questions from you guys.
Thank you again so much, Dr. Salazar. This was such an amazing presentation. We really sense your passion and the love you have for medicine and your patients. So thank you for sharing that with us. Let's see, let's go through some questions. So working with residents, there was some people asking if you see any differences in the amount of DO versus MD physicians who go into emergency medicine, if there are any, and like what you prescribe to those differences.
Well, I'm going to go on the public record here and tell you that MD equals DO. No questions, no arguments. A physician is a physician. Those two different pathways have kind of a different base, a different history, but some of the finest physicians I've ever worked with, I take Joya Singh, for example, one of my first year residents. Phenomenal. She is so freaking amazing. DO, okay? Whitney Potomac, one of my colleagues who did her residency with us and then came back as faculty. One of the greatest physicians that I know, DO. So let me go on the record by saying there is no difference. We should destigmatize, and anybody who's got a question about, the quality of DO training can have a nice conversation with me, and that doesn't usually go well for that person. So that's how strongly I feel about our partnership with DOs. It's an absolute great one. And yes, there are more MDs in my program, but that's just the way it shakes out. I will work with a DO and train a DO in the front lines and risk my lives with them any day.
Great, thank you so much for that. That's really refreshing to hear compared to some of the other specialties we've seen. So thank you for answering that question for us. Another question we had from several people was how often you work with physician assistants or nurse practitioners, and how commonly they're seen in emergency medicine in general.
Yeah, absolutely. We do have, I work with both nurse practitioners and PAs on a daily basis. For example, a part of the emergency department is called the observation unit, is run strictly by nurse practitioners. And I, as the overseeing physician for them, get to work with 4 of them when I work that shift. When I'm working in the emergency department, one of the pods, I work directly with a PA or a nurse practitioner who checks out patients to me. Sometimes when I work fast track, we work directly with a PA or a nurse practitioner. So we see them and work with them on a daily basis. In a well-trained APP, an advanced practice provider, okay, a PA or a nurse practitioner is absolutely invaluable. There's no value to the level of expertise that they bring. I can't put a value to it. That's how phenomenal they are. So yes, I get to work with them. I mentor them. I teach them. I also work with students, nurses, and student nurse practitioners as well. So you name it, we see it. I'm so delighted to be part of a group that is really dedicated to education.
Thank you so much. It's great to hear. And again, the passion just is coming through your voice so well. So we appreciate that. There was a question kind of going back to Texas's current lack of mask mandate. How do you see, does that change anything in the hospital about, being prepared compared to like a year ago? Do we think that there's going to be a rise in cases again? How do you think that impacts our hospitals here?
Yeah, this has been a very predictable virus to a large degree. For example, when the holidays hit, Christmas, New Year's, we knew that January was going to be a tough month for us. And guess what happened? The numbers went up. Okay. So we start making progress, right? Numbers start dipping down because we do the right thing. People start listening a little bit. We have a change in government. This is not a political thing. Many factors go into it, but this is what happens. We start doing good, guys, and then holiday comes up and people do the wrong thing. And now this mask mandate where people are going to go to restaurants at 100% and aerosolize COVID-19 is going to roam around unvaccinated folks. Within the next 3 to 4 weeks, we're going to surge again. We're prepared, but I am here to tell you that it's tough. It's really tough because you see a little bit of daylight at the end, and then your very own government puts you down, and that doesn't feel good. And I'm not the only one. So that's why my mental health and my physical health have to be always kind of atop my priorities. And yes, we will be okay. We're always going to be okay. But rest assured, when this is all said and done, the number of individuals in healthcare who have developed depression, anxiety, mental health disorders, needing to be on medication, insomnia, we're going to find out just how devastating it was. So yes, we're prepared for the right reasons, but we're also prepared for the wrong reasons because we know it's going to surge again.
Yeah, absolutely. We know that. Kind of still going off the preparedness question, in our hopefully soon post-COVID world, how do you see hospitals preparing for any possible future pandemics or epidemics? If, God forbid, we have another one resembling this?
We here, especially in Dallas, we learned great lessons from Ebola. Many of you may not remember this, but the one patient, Mr. Duncan, rest in peace, who came from Liberia, came to a Dallas hospital, was a humbling reminder to all of us in medicine that a preparation was to be paramount. That could have been disastrous. And believe it or not, we owe Mr. Duncan a lot of gratitude because his experience, his very bad experience, taught us a lot about preparedness. And so we were actually prepared for this. I think there's a lot of perception that, oh my God, this hit us really hard. And yes, it was kind of surprising, but we were ready, guys. I've been training a lifetime, a career for this. All the times that we learned about infectious diseases, all the modules and physical training that we did on PPE, and going to hospital meetings and committee meetings and preparedness meetings, training our residents and disaster day. So we train a lifetime to work through this pandemic. And so I think that the lessons that we learned for this one is PPE needs to be a much better utilized resource for hospitals. We thought we had enough until we got a nasty airborne virus like COVID-19. I think that's what you're going to see the most changing is just the PPE supply going forward.
Great, thank you again for that insight. I guess we can do one more question before we have a quick wrap-up question. Throughout the whole presentation, there were a ton of questions and comments on mental health of providers. And you kind of touched on that a little bit in your previous answer, but what have you personally seen? What effects has it had on people that you've worked with? And how do you think that going forward, we can help out providers in their mental health aspects?
Amongst the ranks of frontline personnel, remember there's different, I'm not putting any down. There is a true difference between front lines and you have a clinic-based type of practice and you don't see patients no matter what they have. Perhaps that's not the right word for you. So I can only speak of like truly frontline, like we will see anything that comes to the door no matter what. The number of personnel and colleagues who are dealing with things like insomnia, nurses, the experience with nurses who are now on psychoactive agents such as SSRIs, antidepressants, is higher. And I can tell you that the use of substances, particularly alcohol, is more than likely up. I don't have data for that last one, but it's there. It's hard. You only have a finite amount of coping mechanisms for it. Our health systems have been remarkably gracious in giving us the resources that we need, completely retaliation free. And they've given us a wealth of opportunities, shall we need it, to speak privately to mental health professionals, to have a structured way of taking care of your mental health, not just kind of as needed. And those resources have been readily made available to us. Perhaps that's a second item that we learned from all of this and better preparedness is to mobilize these resources even earlier before a pandemic hits. We didn't know a lot about what was going to happen to our mental health. But I'm here to tell you, I am standing here with you because I have taken the appropriate steps, but even people like me suffer. Okay. And so the main advice that I have for you, whether you're in healthcare or not, if you're going through a tough time with your mental health, never, ever hesitate to seek help. That also needs to be destigmatized. And if you need that listening ear, ask a friend, ask a colleague, ask me. I'm more than happy to. Let's destigmatize mental health. And that's particularly true now, especially for frontline personnel.
Thank you so much for speaking on that. Yasmin and I were both psychology majors, so we appreciate this conversation a lot. And I guess our last question as we wrap up before we get to the announcement is you've been giving us a lot of great pieces of advice throughout this whole presentation, but if you could leave us with one lasting piece of advice as pre-med students undergoing our applications and our journeys during this pandemic, what that would be. Yeah.
I talk about linearity a lot. So what that means is the following. I see this a lot in pre-healths, but it's applicable to all walks of life. This happens to people like me as pre-healths. We have one path and one path only. The path to being a clinician, a physician, a PA, a nurse. And that path is so linear, guys, that all the beautiful trees on the outside, all the beautiful animals, all the beautiful flowers around you. You get so blinded to life that you forget to take care of yourself and to be a human being. Okay. And so my best advice to you is the goal of being a clinician is phenomenal. Don't forget to be a human being, to take care of your family, to take care of your friends, to travel, to get to know the world, learn different languages, network aggressively, get to know other disciplines, always lend an opening ear if another opportunity comes along. You may be surprised, because if your path is too linear and it's too direct, you really risk being narrow-minded when it comes to medicine. And narrow-minded clinicians are out there, and they're not empathetic individuals. They're not the type of people that you want next to you when SHIT hits the fan, forgive the word. Okay. You want to be the type of clinician that when SHIT hits the fan and you really need somebody to be there for you, they'll be there for you, not just as a good physician or a good nurse, a good PA. They're there as human beings as well. So don't forget to take care of those aspects in your human life. Okay. Linearity can be a bad thing. Pay attention to those trees, animals, and flowers around you. You'll be surprised what's out there.
Thank you so much. We love that advice. That wraps up our presentation. And so now if you want to go ahead with your special announcement that we've been waiting for the whole time.
Gladly, guys. So a while back, we came up with the idea of we wanted to give back to our communities even more, and pre-health overall. And the demand is there for a podcast. We have planned the podcast for a while. We have our first topic, and that's not a secret. The topic is going to be medical missions. Is that a good idea for pre-health? And you might be surprised at what you're going to hear. Okay, we're going to launch that in the spring. We were going to put it on our learning management system for registered users. However, I, as the medical director, have made the decision to make it a free open access podcast for anyone, even if you're not registered with VCOP, to go ahead and enjoy it. And so we're going to be launching it across various platforms where you can download it. And it's going to be a series of things. So the first two are going to be medical missions. Is that a good idea for pre-health? The second one is going to be EMT. Should I get my EMT as a pre-health? And we're going to be tackling things like mental health, applications, admissions committees, extracurriculars. We are even going to have one that was requested, is what is it like working as an administrator for Dr. Salazar, Dr. Fowler. So Jamie is one of our administrative assistants, and people are very curious to see what we're really like at work. So we're going to put Jamie in one of our podcasts. We're going to make it free open access so that you guys enjoy it at no cost to you, for free. And so you guys are the first ones to know about that. So that's my big announcement for you.
That's awesome. Thank you so much. If you open up the chat, people are super excited to be able to listen to that. So we'll definitely be posting about that on our stories when the time comes. And thank you so much. Yeah, the chat's just kind of blowing up. Everyone's super happy about the news.
I'm glad. You guys are phenomenal. I am so very proud of each and every one of you. Keep up the good work. As I always tell people, a young Guatemalan pre-health always dreamed of making it into the big leagues, and he did. I didn't do it alone, but if I can do it, guys, you can do it. So get after it. Let's go get it together.
Thank you. And we'll definitely stay in touch, and we hope you have a great rest of your weekend, and we will talk to you soon.
Thank you all so very much, guys.